Next speaker is going to be Dr. Dake. Nothing better than him to speak to us. He's been involved in a clinical trial with a new drug-eluting stent. He's going to talk about the Lesion stents and drug-eluting stents in the SFA. Michael, thanks for coming.
Thank you very much, Marcelo. And we're going to reserve our comments to bare metal stents and drug-eluting stents in the SFA. These are my disclosures. Now, when we talk about peripheral arterial disease, we clearly have set the stage that there's an increasing prevalence as our aging population moves forward, and it's very clinically important, but it's a wide spectrum of disease we're talking about in the SFA. And as you might expect, because of that, there are a wide number of treatment options, and you've heard some of them already. Certainly each has a value, and each works better in certain situations than others. Here's my index case, and this is, I think, what we consider in our country at least sort of standard of care. This task A or B lesion, short total occlusion, and then after, in this case, a drug-coated balloon, but it could have been a plain old balloon angioplasty. We have a result that, at least in this area down here, is less than desirable, and I think in the U.S., probably more than other countries, this usually then leads to stent placement, because we get, obviously, a much more cosmetic, pleasing result. Now, the question is, what else do we get, and is it worthwhile? Now, when we're talking about task A and B lesions, as we just heard by Dr. Yamada, there's clearly, at least from the literature looking at patency, there's no doubt that stents outperform PTA even in these short lesions. And again, both of them suffer from the fact that the longer the lesion length, the less the patency. So they kind of track together. But in the green, you can see results of a number of stent trials versus in PTA, a number of at least arms in PTA trials that were perhaps part of a overall stent protocol, but that's the PTA arm. So clearly, I think this is established, and that's kind of what we believe. But the reality is, it's more complex than that. And part of that has to do with these range of different lesions, and the fact that some lesions are basically prone to have different challenges than others, based on location, length, etc. So in point of fact, of all these different technologies, almost all of them have limitations. And I'm going to talk about stents, and if we're going to talk about stent failure, some of those limitations are dependent on a number of lesion and patient factors. As we discussed, lesion length, but also vessel diameter, location, occlusion stenosis, and a number of patient factors that have been established. So this interaction between the stent and the underlying vessel over time is very complex, and a certain population can lead to this very difficult and vexing problem of in-stent restenosis. So, back to the question. How about the relative effectiveness of a drug-eluting stent versus a bare stent in the SFA? Well, first we have to be clear, we're talking about relatively simple task 2 A and B lesions like these. If we are, we do have some direct head-to-head comparison from the Zilver trial. As you're aware, the Zilver PTX stent is manufactured by Cook, and it combines a self-expanding nitinol stent platform, a second-generation Zilver Flex stent, with the drug paclitaxel, as you've heard about, which, of note, as opposed to coronary stents, is applied without any adjunctive polymer or excipient to only the abluminal side of the wall. You may know coronary stents are basically dead. So the drug is everywhere, luminal, abluminal, all around. But in this self-expanding stent for the SFA, the Quicksilver PTX, it's only on the abluminal side, and there's no polymer, permanent or otherwise, that in some cases has been implicated as a reason for late thrombosis. We looked at the study design. This was entertained a long time ago, and at the time it was first submitted to the FDA, there was no thought to be appropriate, approved stent was always the intercoil, which most people were not using except for popliteal lesions. No other stents were approved. It was thought mandatory that there had to be an approved technology to randomize the drug-eluting stent to, so PTA was chosen. And even back then, it wasn't necessarily exclusively standard of care. But FDA did allow for a secondary randomization, which is so-called almost provisional stenting. So for failed PTA, you could either get randomized to the identical bare Zilver stent or Zilver PTX. and roughly 50% of the patients who went to the PTA arm then had a subsequent secondary randomization because of an unsuccessful or failed PTA. So if we look at the demographics in this trial, there's nothing really to make note of here. 2/3 of the patients, women, about 50% diabetics. If we look at the lesion characteristics of note, and anytime you evaluate any of these studies in the SFA, the first thing that I should go to is the lesion length. And here they're relatively short, to moderately short lesions, 65 millimeters long. So again, right in that task AB that we just talked about 1/3 total occlusions. So happened the test group had slightly higher degree of calcification compared to the balloon group. And now we have 4-year, we've got the 5-year results, they just haven't been analyzed yet. But the 4-year results you can see here, and if we use this very conservative number, which back again when this was entertained was thought to be the most appropriate, which is a peak systolic velocity ratio of less than 2.0. So a duplex ultrasound criteria that's supposed to represent a 50% diameter stenosis. Unfortunately, this 2.0 is sort of more appropriate for native vessels or bypass grafts, not necessarily stented vessels. In fact, it's basically now been, in a couple articles in literature, thought that something more like 2.8 is appropriate. Most of the stent trials use 2.5. So if you were to use 2.5, and since we have the exact peak systolic velocity ratio values, you would shift both of these curves up about 4%. Okay? So if we look at patency out at 4 years and compare Zilver PTX in red to standard of care, which is most probably appropriate out of 4 years, so not PTA, but optimal PTA, that 50% of patients who 4 years earlier were thought to have a beautiful PTA, plus those patients who had provisional stenting randomized to the bare metal stent. We compare them, you can see going out to 4 years, these curves are statistically significantly different in favor of the drug-eluting stent. And that represents, and compared just in the provisional arm, Zilver PTX for suboptimal PTA versus those patients randomized to a bare metal Zilver, that represents a 41% reduction in restenosis, which must be attributed to the drug. And again, comparing these directly at 4 years, the patency curves are statistically significantly different. Now, if we look at stents in the SFA, A represents, this point up here represents Zilver PTX. So in these relatively short task AB lesions, where it may be more difficult to note an incremental benefit of a drug-eluting stent over a bare metal stent, you can still, at least in the direct head-to-head comparison, note a difference in favor. So if we go to more difficult lesions, more complex lesions, the thought is perhaps they would have actually an incrementally better benefit. So in task A and B lesions with stents and bare metal stents, it's about 70%. So in these more complex lesions, such as diffuse SFA disease or in-stent restenosis that we talked about, is the beneficial effect of the drug even more apparent versus a bare metal stent because we have much higher risk factors for restenosis? Well, if we look at 4-year primary patency, this is from the randomized clinical trial data I showed you earlier, and we just make a line at 10 centimeters, you can see in the Zilver PTX, there was no difference in patency out of 4 years between those lesions greater than 10 centimeters and those lesions less than 10 centimeters. And it's very nice because we can see here that if we then layer on the standard of care, optimal PTA plus bare metal stent from a secondary randomization, if we look at those lesions greater than 10 centimeters, these more complex lesions, you can see in green, Zilver PTX greater than 10, in red, Zilver PTX less than 10, again, no difference 4 years, but the black shows the standard of care. Okay? So it appears that makes sense. If we look at more real world from the Zilver PTX single arm update, which is 900 patients over 1,000 stents, and we look specifically at those lesions greater than 15 centimeters, there were 133 long lesions, 83% were total occlusion, and if we compare that, we look at that going out at 12-month patency, again using velocity ratio 2.5, you can see 77% patency for lesions greater than 15. And then what I think is kind of fun, now we start layering on diabetics with long SFA lesions. There were 67 of those, of which about 2/3 were total occlusions. Mean lesion length was 22.4 centimeters, so these are really long, real-world lesions. You can see no difference in these long lesions between the diabetics and non-diabetics. Now, in-stent restenosis, which I thought I'd just touch on briefly, because this is a problem that we all face with in any patient who may be stented. There were 142 patients, lesions with a lesion length of about 13 centimeters with 1/3 total occlusions. And you can see again, between non-in-stent restenosis and in-stent restenosis, surprisingly, yes, there's a difference, and certainly that difference becomes more apparent over the final 6 months in this 12-month analysis. There's really, at the end of 12 months, not that big a difference between in-stent and no in-stent. So clearly there is some drug effect here. And if we look then at these long lesions, and you can see along the axis at the bottom, the lesion length, from Vibrant, which is obviously a stent graft, Durability, which is a long bare stent trial, and Zilver PTX, it appears that the drug does have an incremental benefit. That's the primary patency. Now, I just had the fortune a couple weeks ago, I was in Japan to review this data for the Japan post-market status. In the U.S., the FDA requires to report market status. Somebody may be involved in the Zilver PTX post-market study, and we've enrolled, I think, 18 patients in a trial. Japan enrolled over 900 in 3 months. So we in the U.S. still lag behind most of the world in our ability to actually do high-quality research. And the mean lesion length in these patients in Japan is 15 centimeters, so long lesion. They're holding back, waiting for this technology. And they're, at the ACC, are going to release that data, and it's very exciting. I'd be interested in seeing that when it comes out. And again, I'm going to close with this index case. It's not my case, it's from Andrew Schmidt. I wanted to make sure that he's acknowledged, but it's just one example, albeit extreme, but I think the extreme nature of it helps hammer home a point that the drug really does make a difference. So this is a 64-year-old woman with recurrent ischemia and an SFA occlusion after a PTA 11 months ago. And now she comes in 6.5 months after initial stent placement, and she has this lesion up here, proximal femoral, and then a lesion lower down at the distal edge of the stent. And so that was in-stenting stent. A stent was placed within a stent. And she comes back now 9 months after that and has a 3rd reocclusion. And this was treated with a stent within the existing stent. And now 5 months later, she returns with this 4th reocclusion that you see here on the left. And it was treated with laser-assisted PTA, as you can see there, and placement of Zilver PTX. So again, this is a very, you might say, why in the world didn't they just do surgery or something? But that's not the point. They just chose to do this. So after a 4th reocclusion, they put the Zilver PTX stent. And then this is the angio appearance 32 months post-Zilver. So 57, almost 5 years post the initial PTA. And subsequently, obviously, at 42 months, as written at the bottom, they had a duplex ultrasound which showed no restenosis. So clearly, I'm not saying drug-eluting stents is the be-all, end-all, because it isn't. But I think the drug device paradigm, and we'll all get a chance in the future, hopefully, when the FDA evaluates the results from the Bar-Levant trial and the Medtronic impact trial to have drug-eluting balloons as well, that I think this drug device paradigm is clearly something that there's no going back. Drug-eluting balloons will be the new balloons, drug-eluting stents will be the new stents, and we'll go on from there and see where that takes us. So in conclusion, new generation stents, bare metal stents, certainly increase primary patency over PTA alone. But having said that, drug-eluting stents, certainly in task A and B lesions in a direct head-to-head comparison, are better than non-eluting stents, and there's this initial thought that that benefit is even incremental in longer, more complex lesions. I think it's always important to know when you compare patencies, and you often run a risk of comparing trial-to-trial patencies, but at least when you compare open surgery to endo, you got to remember that the criteria is different. Binary restenosis from a peak-systolic velocity ratio does not equal open or occluded, which is basically the criteria in surgery, so you need to be aware of that. And I think that's becoming increasing recognition that our duplex criteria is a little inexact when we talk about determining patency for endovascular procedures. It really doesn't matter if you have a native vessel or a bypass graft or a stented artery, which one of these criteria you want to use if you're going to compare things side to side. So for task C and D, long segment femoral popliteal lesions, it's reasonable to expect now, at the current state, the 12-month primary patency rates of about 78% for DES and 70% for surgery using a binary restenosis criteria. Thanks very much.
Thank you, Mike. Great talk. Definitely gave us an idea and some updated information about the role of drug-eluting stents in the SFA and lower extremity regularization.